Dr. Samuel Asirvatham, professor in electrophysiology at Mayo Clinic, USA. Dr. Asirvatham is currently a professor of medicine in the Division of Cardiovascular Diseases within the Department of Internal Medicine and a professor of pediatrics in the Division of Pediatric Cardiology within the Department of Pediatric and Adolescent Medicine. He is also Program Director for the Clinical Cardiac Electrophysiology Fellowship and Director of Strategy Collaboration for the Center of Innovation at Mayo Clinic, Rochester. Sir has won the Mayo School of Graduate Medical Education Program Director Award 2020. We heartily welcome you, sir. I would also like to extend a warm welcome to the moderators of the session, Dr. Thomas Alexander Coimbatore, Dr. Arun Gopi Calicut, and the panelists, Dr. N. Visakan Tirupur and Dr. Ges Balaji Coimbatore and Dr. Rupesh Sharjah. Thank you, sir. Over to Dr. Samuel Asirvatham.
Going to spend the next 30 minutes or so going over ventricular tachycardia, focusing on what the general cardiologist, internist, dealing with patients with arrhythmia should be aware of. Particular case that we will discuss is when the heart is normal. Normal heart ventricular tachycardia. First skill for the physician for normal heart VT is to understand the 12-lead electrocardiogram. So ventricular tachycardia, each and every ECG is a reflection of where in the heart the arrhythmia is arising from. There are two patterns that we must commit to our mind. The first is this. We see a left bundle branch block morphology pattern. Left bundle pattern means left ventricle is late, so origin of the arrhythmia is in the right ventricle. We see leads 2, 3, and AVF are very strongly positive. These are the inferior leads, so strongly positive means vector is going towards the feet, so originating near the head. Near the head, with regards to the heart, is the outflow tract. The number one most common arrhythmia from the ventricle in patients with normal hearts is right ventricular outflow tract tachycardia. This pattern is important to recognize because it is rarely life-threatening. It does not require evaluation for coronary artery disease and has a unique management scenario. It's very commonly seen in the ICU setting or patients who are under a lot of stress, physical or emotional stress. Typically, especially in men, it is an exercise-provoked arrhythmia. So this is the person exercising and then running out of breath. The heart rate doesn't come down when they are trying to relax, they are stopped exercising. Occasionally, it can come in salvos, especially in women, and here it can be along with the cycle where they can have little salvos of this tachycardia. The prognosis is excellent. This should not be considered as patient who is at risk of sudden death or requires an ICD, etc. They do not. It is a good prognosis arrhythmia. The symptoms are the problem. They can be very lifestyle altering. Generally, you can manage with beta blockers, occasionally calcium channel blockers. But if the drugs are not working or not tolerated, giving rise to side effects, this is a very common arrhythmia to refer to an electrophysiologist for ablation. The ablation procedure is quite straightforward. Catheters are put into the heart. You find the exact site of the arrhythmia and you ablate. The success rate for this type of tachycardia is very high, but the referring cardiologist should be aware of some of the complications, some of the difficulties, and try to anticipate from the ECG which cases may be not so straightforward. So this patient, if we look at, is not having tachycardia, but PVCs in a bigeminal pattern. And if you see the PVC pattern, it also is left bundle branch block, strongly positive in 2, 3, and AVF, right ventricular outflow tract. But there is a subtle clue that this patient will not be straightforward for an ablation. And that is, instead of complete QS complex in V1, there is a small R wave in V1. Small R wave in V1 means some caution or care during the mapping and ablation is required. Here is an example of how the mapping is done. Various systems are available. Here, the white refers to the very first spot in the heart where the abnormal activation starts. It's like throwing a pebble inside the pond. From there, it's spreading. Our job is to get to that site and ablate it. Now, if you notice here, I have marked on this map PV for pulmonary valve. Some of you may ask, how can you have the arrhythmia begin in the pulmonary artery above the pulmonary valve? That is no longer cardiac tissue, it's an artery. And this is actually a common site for the arrhythmias to come from. The valve itself is seated on the outflow tract muscle, and as a result, there is myocardial sleeves or tongues that extend into the great artery, the pulmonary artery, and can be the start of the tachycardia. Why is this difficult, or why are there complications? And the reason is the outflow tract is a very heterogeneous site. So if we look at this, this is a left anterior projection onto the heart. You notice the catheter near the pulmonary valve, aortic valve catheter, recording the conduction system, his bundle catheter, coronary arteriogram, and a catheter in the venous system. All these structures are close together. And as a result, the EKG pattern from one site versus another, closer to the artery, closer to the valve, can be difficult to distinguish and requires some precise mapping and some time to get to the right location and ablate. Few words about how to interpret the electrocardiogram when you are looking at the outflow tract. All the cardiologists in the room will remember, even though the right ventricle inflow is to the right of the body compared to the left ventricular inflow, the outflow tracts cross each other. You'll remember we auscultate pulmonary murmurs on the left side of the body because of this crossing over of the outflow tracts. This crossing over produces some unique adjacency of the left and right ventricular outflow tracts, where often both of these outflow tracts require to be mapped and targeted for ablation. Here is another view of the same issue, the right ventricular outflow tract, just over the left ventricular outflow tract. Now, this region of the heart, especially this posterior region near the valve, up to where the aortic valve is shown in this section, is where these arrhythmias arise from. The reason for this is probably because the embryological origin of this tissue between where we have the aortic valve and the pulmonary valve is very different. It does not come from the same primitive cardiac tube that most of the cardiac chambers come from. As a result, our mapping and ablation, the energy delivery, the heat, is close to the arterial system and also close to the valves. And both these structures can give some problems, either because of risk of damage or some catheter stability when we are trying to map and ablate. Here is another key way to look at where these arrhythmias come: the aortic valve and the three sinuses of Valsalva. Notice the pulmonary outflow tract and pulmonary valve. Just behind it, we are in the right coronary sinus of Valsalva, very common location for where we place the catheter to deliver the energy to the tissues in this location. Now, a second reason why these arrhythmias are common is when we are developing in our mother's womb as a fetus, we actually have conduction tissue in the outflow tract. This conduction tissue can be thought of like a right superior fascicle or a left superior fascicles, and they connect back to the hismon. But as we get close to birth, some of these disappear, they may lose their connection to the rest of the conduction system. They remain there and can be the cause of this catecholamine-driven tachycardias in the outflow tract. For the general cardiologist, this is the point once you have really understood the ECG of outflow tract tachycardia. Left bundle, strong inferior axis. That means tall R wave in V1 in leads 2, 3, and AVF. We must pay attention to this R wave in lead V1. It's not a complete left bundle pattern, but little R wave. The bigger that R wave, what it means is the actual focus where the arrhythmia is coming is away from V1. It's deeper in the heart tissue, closer to the outflow septum, closer to the aortic valve, or in some instances around the mitral annulus itself. So maybe some of you can just look at this ECG of PVCs. Young man at that time, he was in medical school, had developed a lot of this PVCs, eventually developed a cardiomyopathy, VT, and was even being considered possibly for cardiac transplantation. And the story was repeat attempts at ablation were difficult, but eventually was successful. Here you notice a big difference from the ones that I have shown you. Yes, leads 2, 3, and AVF are strongly positive. Positive means far away from the feet, near the head, outflow tract. But V1 has a right bundle branch block pattern. Right ventricle is late. So this is left ventricular outflow tract, very high. And in fact, this young man's focus of arrhythmia was close to and adjacent to the ostium of the left main coronary artery. It can be challenging cases to try to map and ablate in that region. Why is it that he developed this cardiomyopathy? And for the general cardiologist, for the internist, for the primary provider, this entity of PVCs that can be the sole cause of cardiomyopathy is important to understand. It is one of the very few completely treatable cardiomyopathies. So it's mostly an issue of too many PVCs, thousands and thousands, sometimes 30,000, 35,000 PVCs in a given day. In some patients, not all, but in some patients, over time gives rise to low ventricular function and gives, in the later stages, a clinical picture very similar to idiopathic dilated cardiomyopathy. So usually we find these patients in that evolving stage. EF is coming down, ejection fraction is coming down, and you see these frequent PVCs. What is some of the decision making that the cardiologist should think about? First, the ejection fraction magnitude of decrease is a function of how many PVCs. So the more number of PVCs, the more likely over time that ventricular dysfunction will happen. There is no real understanding at this point why some patients may have the same high volume of PVCs but never develop left ventricular dysfunction. They need to be monitored because of this possibility. But if you are evaluating a cardiomyopathy patient and notice frequent PVCs, this thought must occur to you because it is a treatable cause. If the PVCs are eliminated, the ventricular function improves. It comes back towards normal. Now, there is a bit of a riddle here, a conundrum. PVCs, when frequent, non-sustained VT when frequent, can give rise to cardiomyopathy. But cardiomyopathy can be from many reasons, and the disease of the diseased heart can give rise to PVCs and VT as well. So it is like the chicken and egg. How does the internist or cardiologist figure out which came first? The key is looking at the morphology of the PVCs. That means the ECG pattern. Are all the PVCs, are all the non-sustained VTs looking similar to each other? If they are all similar to each other, it suggests there is one source. Why would someone with some other cause of cardiomyopathy, ischemia, laminopathy, non-compaction, why would they get all PVCs from one site? Similarly, if the PVCs, non-sustained VT, are different morphologies, it suggests a more widespread disease process, and unfortunately, in that patient, management is more difficult because eliminating the PVCs or VT is only a small part of the overall problem. Now, once that pattern is fixed in your mind, if you will see the next 100 patients with normal heart and who have VT or PVCs that are frequent and monomorphic, they will be the outflow pattern. The next group is also normal heart VT, usually younger patients, also tends to be exercise related and has quite a different pattern on the ECG. Here you will see an almost perfect right bundle branch block type pattern. And if you did not notice some of these fusion beats, you may even think this is a conducted tachycardia, an SVT. But once you have established it's a VT, if you now look at leads 2, 3, and AVF, you notice it's the opposite. It is all negative, originating closer to the feet than the head. This is also a normal heart VT, and the cause of this is small circuits that are related to the conduction system of the heart. Because they are originating in the conduction system, they tend to look very similar to a bundle branch block pattern, a typical bundle branch block pattern. Here, the exercise-related VT can be a little faster than outflow tract tachycardia. Patients may be slightly more symptomatic, but this also is not fatal. And this pattern also, if untreated, can give rise to cardiomyopathy, but not as frequently seen clinically as the outflow tract pattern. The electrophysiologist looks for very sharp, meaning conduction tissue signals that signify where the source of this arrhythmia or circuit for this arrhythmia may be rising and target them for ablation. The general cardiologist or imaging cardiologist should be aware that sometimes this normal heart fascicular type tachycardia, conduction system tachycardia, can arise from the endocavitary structures of the heart. Sometimes the papillary muscle, sometimes these adjacent fibers to the papillary muscle connecting the septum to the papillary muscle, or sometimes these distinct cords or false tendons that can house the conduction system, and presumably from the tension from the beating heart can be the source of the tachycardia. Now, I want to contrast what I have said to you with the next 10 minutes on how you manage VT in the abnormal heart. The normal heart VT is what the general cardiologist will see. Patient coming with PVCs. It is not the patient with collapse. It's not the patient who already has a defibrillator. Patient with symptomatic PVCs, incidentally noted PVCs, exercise treadmill has an outflow tract tachycardia. And that pattern is what we have discussed, and hopefully you are familiar with, and you appreciate that you can try beta blockers and you have the option of referral to an electrophysiologist to eliminate the arrhythmia. On the other hand, abnormal heart VT is a very different story. Here also you may get monomorphic VT. These VTs are not as a result of some development issue with the heart, but a result of scar. The reason that abnormal hearts give VT is scar. Scar can be from myocardial infarction, could be from healed myocarditis, or could be one of the inherited scarring types of cardiomyopathy, for example, patients with the lamin A disorder. Now, what is it about the scar? The key here is dead tissue does not give rise to VT. The problem is almost scarred tissue. Here we have mummified myocardium. Maybe the patient had an ischemic event, partial effective thrombolysis, has an infarction, but there is surviving myocardial fibers within the scar. It is these surviving fibers that can form the circuit of the tachycardia. We should appreciate that just hypertrophy and dilation themselves can give rise to ventricular tachycardias. The reason this is true with hypertrophy is because there can be relative ischemia and some scarring or fibrosis, many times seen in people with massive hypertrophy when MRI with gadolinium, for example, is done. Dilation increases the size of the heart, the diameter, the circumference, and makes circuits more likely to occur. Inflammation and injury. When we have an acute myocardial infarction, the scar is not yet formed. The ischemia and resulting inflammation may produce automatic tachycardias and can produce polymorphic tachycardias. But the monomorphic fixed rate tachycardia that you will see is a reflection of a prior event. It's previous scar that has now created the right milieu for setting up circuits. Now we should know that the reason ablation is not a cure in patients with diseased hearts and why we recommend a defibrillator in VT in diseased hearts, but not in the single source VTs of normal hearts, is because of the nature of the scar and the surviving myocardium. There are any number of possible circuits that can develop, maybe at this point in time, maybe at a future point in time. And if there is ischemia elsewhere, at a distance, for example, the VT can provoke polymorphic arrhythmias and ventricular fibrillation. The role for ablation and referral to an electrophysiologist in these cases is after the defibrillator has been placed to try to prevent the shocks and minimize the amount of VT, both with a combination of ablation and antiarrhythmic therapy. Now, one of the things you should be aware of when counseling patients is if they do not tolerate the ventricular tachycardia, they become hemodynamically unstable. The referring physician may be under the impression that patient cannot be ablated. Don't we need to induce the tachycardia in order to be able to map and ablate it? The answer is no. In many times, it is possible to simply ablate these surviving cells, these channels within the scar and connecting one scar to another that has benefit in minimizing the chance of shocks or future VTs. So this is the pattern in which we do this. The catheter goes, identifies signals suggestive of living tissue, but tissue that is very close to dead tissue or scar, separated often from the QRS. and these are then targeted for ablation. And I will just finish up with a few clinical scenarios that the general cardiologist must be aware of as scarring disorders that can give rise to VT. One, most of you are well aware of. Dr. Narasimhan has really spent a lot of effort in making all of us understand how common the chronic inflammatory disorders are in scarring in the heart. Here, the telltale sign is the heart block along with scar, heart block along with PVC, heart block along with VT. And the diagnosis that we need to consider is sarcoidosis, a combination of anti-inflammatory therapy, ablation in many patients, using a defibrillator with the pacing function necessary because of the heart block, and often also some antiarrhythmic therapy. Key is septal origin region for this arrhythmia. Last thing that I will say is, when in doubt, when there is no ischemia and we are thinking about future possibility of scar and VT, there is a role for endomyocardial biopsy that can help in making the diagnosis not only of sarcoidosis, but other chronic inflammatory disorders, sometimes acute inflammatory disorders, viral myocarditis, or simply the absence of active inflammation helps you guide therapy and thinking more in terms of antiarrhythmic therapy, ablation, along with the backup defibrillator. So to summarize, as general cardiologist, what do you need to remember about ventricular tachycardia? First, the sharp distinction between normal heart VT and abnormal heart VT. Normal heart VT is what you will be presented with. You must commit to your mind the two patterns of normal heart VT. Left bundle branch pattern with strong inferior axis, exercise or stress related, beta blockers, calcium channel blockers, or targeted ablation. The second, right bundle branch block pattern, usually also exercise related with superior axis, negative in 2-3 AVF, conduction system origin arrhythmia, can also be managed with beta blockers, calcium channel blockers, perhaps a little better with calcium channel blockers, can also be targeted for ablation. Do not forget the entity of PVC causing as the sole cause of a treatable form of cardiomyopathy. Contrast with abnormal heart, it is scar and living tissue interspersed within the scar. This is a much more dangerous condition. It can be fatal and is often the mode of death in patients who have structurally abnormal hearts. When feasible, we need to think of combined therapies, a defibrillator to prevent death, ablation and medication to prevent ICD shocks, and the back of your mind thinking about inflammatory processes that can sometimes be amenable to specific therapy, including anti-inflammatory and occasionally anti-infectious therapy. I'll stop there. Thank you very much for your attention.